honor for me as a course director of a live program, which is the atrial fibrillation value education curriculum. This wave 3 this year. We have already in last year, we have 6 waves with a live program. This is sponsored by Pfizer and endorsed by ECC chapter of Egypt. My name is Mohammed Sobhi. He's a professor of cardiology at Alexandria University and the AIG steering committee of the American College of Cardiology chapters in the Middle East and Africa. I prepared these waves with my colleagues, and today we'll have a very interesting scientific program, and we have an international figure, Dr. Fred Kuzumoto. Dr. Fred is, welcome, Dr. Kuzumoto. He's served as the chair for the 2018 HACC-HRS bradycardia guidelines, 2017 HACC-HRS ventricular arrhythmia guidelines, evidence-based committee, 2017 HRS cardiovascular implantable electronic service, their device lead management and extraction consensus statement. 2014 also is a HRS, ECC, HA, ICD therapy in patients who are not included or were represented in the clinical trial consensus statements. Dr. Kuzumoto is working in Mayo Clinic in Florida. Welcome, Dr. Fred, with us to have presenting 2 lectures, and we have a discussion in between. And also I have the honor to introduce my colleagues at the panel discussant or panelist, Professor Hani Raghi, Professor of Cardiology, National Heart Institute.
Hi.
Dr. Hani, introduce yourself, please.
Hi, I'm Hani Raghi. I'm a cardiologist at Egypt Heart Institute. I have a particular interest in getting Egypt involved in international research in atrial fibrillation. I've been part of, I've been the PI for the Gloria registry in the Xanthus registry in Egypt. And, you know, one of my major areas of interest is atrial fibrillation and novel anticoagulants. And I'm so honored to be here. I know who's on the panel. I read everything, and I'm just thrilled to be with all of you. Thank you.
Okay, and also the second panelist for discussion, Professor Lamia Allam, Professor of Electrophysiology at Ain Shams University. Before she speaks about herself, I'm honored and glad to have Lamia. I know her since she was so young, when just starting to be met the exam and exam day for the first shot. She passed successfully, and also in coming from the spreading, changing from to be upgraded from lecturers to assistant professor. I have the honor also to examine her and found it successfully. She is one of the youngest lady in EPS in Egypt. She's doing a lot. Lamia, introduce yourself, please, to all the Fred and all of us.
Okay, I'm Dr. Lamia Allam, Associate Professor of Cardiology and Cardiac Electrophysiology. I am specialized in interventional electrophysiology and C-arm, cardiac rhythm devices implantation. I am one of the members in the Egyptian Fellowship of Cardiac Electrophysiology, member of the ERA, member of the ECRA, and I am so interested in the ablation of atrial fibrillation. I have an experience enough in RF ablation and cryoablation for EF ablation. And of course, it is an interesting field today to discuss this type of arrhythmias, because it is one of the commonest, especially it is commonest actually arrhythmia all over the world, and it's updated every year in the way of the management, in the way of the searching of subclinical EF and diagnosis. And I am honored today to be with one of the eminent, Dr. Fred Kuzumoto, Mayo Clinic, Florida, and I actually follow him in his videos and his preparation in conferences for HERS and ACC. So I am so honored today to be with you today, actually. Thank you.
So as you can see, we have 3 experts, and we have also 2 speakers which will join us, Professor Said Farak from Zayazi and Professor Ahmad Mukhtar from Alexandria University as a cases. Let's start the webinar by Dr. Fred. Introduce yourself and start the first lecture.
Well, Mohammed, thank you. It's so wonderful to be among friends, old friends, Mohammed, and to meet new friends here in Egypt. And I'm really honored by this, and I'm very excited to share this lecture with you. So let me go ahead and start sharing my screen. So hopefully you're seeing my screen. Is that correct? I've done it correctly?
Yes.
Perfect.
Yes, okay.
Wonderful. So for the first lecture, for the next 15 minutes or so, I'd like to really talk about sort of this atrial fibrillation update in 2021. And I have no financial disclosures, nor am I going to talk about any off-label usage. When we talk about atrial fibrillation, really we think, first of all, about the detection and perhaps even prevention, and that'll be the topic of my second lecture. But, when someone has established atrial fibrillation, it really is thinking about stroke risk and then management of symptoms. So I just wanted to provide an update. We can't be comprehensive here on these two large topics, but I'm sure during the panel discussion, we'll have a lot of wonderful discussion about these issues. So let's talk about stroke risk and sort of what's new. Well, a couple of things that are new. I wanted to focus a few slides just on valvular heart disease and atrial fibrillation. This past year, RIVER was trialed. The RIVER trial was published and presented. And this is the rivaroxaban for valvular heart disease and atrial fibrillation. And this was an important trial. So this was from Brazil, 1,000 patients with bioprosthetic mitral valves. And they were randomized either to warfarin or rivaroxaban. And for, remember, for all of us, we worry about what does non-valvular atrial fibrillation mean? And they studied these patients and followed them with a primary outcome then of death, major cardiovascular events, which you can see could include stroke or systemic emboli or even heart failure hospitalization or major bleeding. And you can really see when you look at the incidence of the primary endpoints of either warfarin in red or rivaroxaban in blue, in fact, there was really no difference. And certainly it appeared that the rivaroxaban was non-inferior by statistical methods to warfarin. So it's clearly something that we can think about and then is safe. The other study that I wanted to bring up just here, and there have been multiple others, particularly with Atlantis just being presented at this past ACC, but I did want to bring up this notion of anticoagulation in patients with TAVR. So in this French registry analysis, where they took nearly 25,000 patients who underwent TAVR from two large French registries, not surprisingly, about a third of them required oral anticoagulation, mainly for atrial fibrillation. And among those, about 25% of them received direct oral anticoagulants. So the investigators did a phenomenal job. This is a registry of doing propensity matching. And when they did that, you can actually see when you look at ischemic stroke on top or major bleeding below, it did appear that the DOAC, again shown in blue here, was associated with decreased events, either with stroke or major bleeding. And that really then leads us, to the fact that when we talk about valvular heart disease, nowadays, whether it be the European guidelines or the ACC, AHA, HRS guidelines, when we talk about valvular heart disease, we are now really talking about a specific population. Those patients with mitral stenosis, obviously important in Egypt with rheumatic heart disease or mechanical prosthetic valve. But everything else, including bioprosthetic valves, then would be patients who would be eligible for the new oral anticoagulants. Or now, I guess, since they've been around for a while, really better to be called direct oral anticoagulants. It's also important to note that this anticoagulation regimen is far safer than, our old standard warfarin. This is, again, a Medicare claims analysis, and we can talk about sort of the pros and cons of these sorts of analyses. But you can see when looked at for either death, ischemic stroke, or major bleeding as a combined endpoint, when you took then frail patients who, had significant frailty or were near frailty, and these have specific criteria. In fact, it appeared that using a DOAC, and I show apixaban here, in fact, was associated with a decrease in significant events. You can see, not surprisingly, that for the non-frail patients, in fact, the difference between the apixaban and warfarin, while still there, was less striking, really getting to the point that one of the wonderful things about the direct oral anticoagulants is that they are far safer and have a wider therapeutic window than warfarin, and for that reason can be used a lot more safely. The other thing I wanted to highlight here is this notion of continued LAA thrombus and silent cerebral infarcts, even on those patients with anticoagulation. So on the left, there's a central illustration of a meta-analysis of left atrial appendage thrombosis in patients who were anticoagulated, who were either undergoing cardioversion or catheter ablation. And in fact, you can see that there appeared to be a significant amount of thrombus that was non-trivial. It's relatively small. You can see the prevalence numbers there, but still not zero. You can see that whether you were on a vitamin K antagonist or a DOAC, in fact, that didn't seem to be different. It did seem that if you were in those patients who have paroxysmal AFib compared to non-paroxysmal AFib, there seemed to be a reduced incidence. And I'll be curious to hear what Lamia says, but my bias generally, particularly if we're going to do an anatomic approach for ablation with pulmonary vein isolation, is to try to do that ablation in sinus rhythm. Again, to then hopefully then reduce the likelihood then of some sort of left atrial appendage thrombus. I also wanted to bring up the Swiss AF study. This was presented as a late-breaking clinical trial at the HRS virtual program Science 2020, and I think it's an important message. In Swiss AF, there were nearly 2,000 patients who they then followed for several years. And what's important to note that the great majority of them were on anticoagulation, 90%, and that despite this anticoagulation, in fact, almost 6% of the patients had evidence of cerebral infarcts, silent, so they didn't have overt strokes when they underwent MRI imaging, and that the likelihood of having those cerebral infarcts was higher if you had more risk factors for stroke, if your CHA2DS2-VASc score was higher. I think that this is important for us as electrophysiologists and as cardiologists to realize, okay, if you have someone with atrial fibrillation, it's not just anticoagulation only and leave it at that. You have to treat these patients holistically. You have to think about their hypertension, their diabetes, and other causes for their stroke. So the points that I wanted to emphasize that I thought were really important this past half year was that, number one, that DOACs should be considered appropriate for most patients with, quote, valvular heart disease, end quote. It's really a small group of patients where DOACs should not be used. The DOACs seem to be associated with better outcomes in patients who are frail. I want to emphasize that there are silent cerebral infarcts that continue despite patients with atrial fibrillation being on anticoagulation, stressing the importance of a holistic approach, that there is this notion of left atrial appendage thrombus despite being on anticoagulation, or that patients have strokes due to other causes. So in the last half of this, I'd like to talk then about management. And we have been informed for many years by the AFFIRM trial. And this is an important trial that really changed the way we do clinical practice. 4,000 patients with atrial fibrillation were randomized either to a rhythm control or a rate control strategy. And you can see generally mostly men, about 70 years of age, about 3/4 of them with high blood pressure and with a normal left ventricular ejection fraction. And we're all aware of these results. So whether rhythm or rate control, in fact, when you looked at overall mortality, there didn't appear to be a difference. Remember that these studies were done almost 20 years ago now. And with pre-specified covariates associated with survival, it's very interesting. So remember that in AFFIRM, if you're randomized to a rate control strategy, in fact, a full third of those patients were actually in sinus rhythm at their last ECG. Conversely, for those patients who were randomized to a rhythm control strategy, a full third of them were actually in atrial fibrillation at the end of the trial. So when they looked at, all right, if you're in sinus rhythm, regardless of what arm you were in, what was the likelihood of survival? In fact, there was a 50% reduction in mortality in those patients with sinus rhythm. In addition, not surprisingly, as we now know as standard of care, anticoagulation use was also associated with a reduction in mortality. But interestingly, digoxin and antiarrhythmic medications were associated with an increased risk. And while this is, again, a complex topic, it does point out that these antiarrhythmic medications that we use do have important side effects. And particularly important when we're giving these drugs for patients for a nuisance arrhythmia, right? So if you're giving them potentially a life-threatening side effect, such as Torsades de Pointes, for then a nuisance arrhythmia, such as atrial fibrillation, while that is reasonable, it should always be kept at top of the mind and shared with patients. At last year's European Society of Cardiology trial, the EAST-AF-NET4 trial was published. And this was an incredibly important trial that has really changed the way we're thinking about the management of atrial fibrillation. And I would be remiss if I didn't bring this up as one of the most important trials that has been published here in the past year. Just to remind everybody, 2,800 patients with recent AF, less than 12 months, and stroke risk factors. They were trying to do this to enrich the population. So these were patients who had a prior TIA or were older or had CHADS VAS score risks, usually diabetes or high blood pressure, left ventricular hypertrophy, or reduced renal function. And these patients were then randomized to rhythm or rate control. And I wanted to highlight this. People look at this as sort of an ablation trial. It's really not. You can see the medications. The type 1C drugs shown in green, propafenone and flecainide, amiodarone in pink, and dronedarone in sort of that tan color. AF ablation, while used in some patients primarily as initial therapy, and 20% of patients in the rhythm control arm underwent ablation at 2 years, know, though, that this was a strategy trial, looking at this notion of early rhythm control. And what was important about that is that rhythm control, early rhythm control, shown in blue here, was associated with a decrease in the primary outcome. And this primary outcome was a combination of CV death, stroke, heart failure hospitalization, and ACS hospitalization. And I've shown you the individual endpoints in the small table on the right. And while you can see that some don't reach statistical significance, again, because the numbers are then smaller as opposed to combining them all, it's important for us to note that all of those endpoints are trending in the correct direction. In the table on the bottom left, you can in fact see kind of the population. It's kind of the usual sorts of patients that we see in our clinic. General age, about 70 years of age, about half were female. So the investigators are to be congratulated for ensuring this equal distribution of men and women in their trials. You can see a third of patients with first atrial fibrillation, paroxysmal atrial fibrillation, or persistent atrial fibrillation. Interestingly, a third of them were completely asymptomatic, and about a third of them, again, had prior cardioversions. More recently, at ACC, Tony Tang presented the RAFT-AF trial. So this was a similar sort of idea as in AFFIRM with rhythm versus rate control, but the rhythm control, instead of being drug-based, remember that in AFFIRM, most of the patients received amiodarone with a smattering of patients receiving sotalol. In this ablation-based rhythm control, this did not reach statistical significance, but it's important for us all to acknowledge that this is a small study, 400 patients, and that the trial was stopped in 2018 for slow enrollment and futility. And what's interesting to see is that you can see that the curves, at least visually, begin to separate at about 2 years. So one wonders if the trial were able to continue to have enrolled, would there have been a significant difference then in survival associated with an ablation-based rhythm control strategy? How about patients with heart failure? So again, the AF-CHF trial by Waugh and colleagues from Canada, an important trial. So this was AFFIRM in patients with heart failure. So 1,400 patients with AF, heart failure and reduced ejection fraction, LVEF, less than 35% for this trial, were then randomized to rhythm or rate control strategies. And you can really see whether you were in rhythm or rate control, the survival rate, cardiovascular death in this case, was essentially equal. We began thinking, though, a little bit differently about patients with heart failure and the notion of rhythm control with the publication of the CASTLE-AF trial. In the CASTLE AF trial, 360 patients with persistent AF, LVEF less than 35%, then class 2 or 3 heart failure, and optimized rate control were then randomized either to medical therapy to have the patient then return to sinus rhythm, antiarrhythmic drugs, or ablation. And what was striking in this trial is that there appeared to be a survival advantage. Here you can see that met statistical significance with a 50% reduction in mortality associated with ablation. So is this a specialized population? Well, the ablationists will tell you, okay, well, we're just better now at maintaining sinus rhythm compared to previously. But here I show you the likelihood of being in sinus rhythm, shown in blue, in AF-CHF in the rhythm control arm compared to the ablation arm in CASTLE AF. And in fact, you can see that patients were likely, 2/3 of the patients in the rhythm control arm in AF-CHF were actually in sinus rhythm, a higher percentage, I must say, than the ablation arm in CASTLE AF. So what accounts for these differences? I actually think the difference lies in the table 1. In the table 1 for AF-CHF, you can see these were pretty ill patients. A third had had prior cardioversions, 40% had had prior antiarrhythmic therapy, 50% with a recent heart failure hospitalization. The average EF was about 27%, and only about a third had non-ischemic cardiomyopathy. Conversely, CASTLE AF, 363 patients were randomized, but 3,000 people were screened. So this is a very specialized group, highly selected. And while a significant number had failed amiodarone use, their EFs were better and they were more likely to have non-ischemic cardiomyopathy or perhaps tachycardia-induced cardiomyopathy. So I think when we're thinking about those patients who we should have undertake a rhythm control strategy, we have to think about these differences. Several weeks ago at Heart Rhythm Society 2021 in Boston, in fact, the East AFNet4 trial investigators presented their heart failure cohort. So this was a pre-specified analysis and looked at those patients who underwent early rhythm control versus usual care. And you can see that there seemed to be a benefit associated in these patients with heart failure with early rhythm control. Again, you can see the combined outcome reached statistical significance with nearly a 25% reduction in the combined outcome with appropriate directionality shown in cardiovascular death, stroke, heart failure, hospitalization, and even ACS hospitalization. You can see that stroke and heart failure hospitalization did not reach statistical significance because of the small numbers. But it's intriguing, and the data now seems to be consistent that management, aggressive management of these patients who have heart failure associated with atrial fibrillation ought to be considered. For the last few slides, I'd like to comment on a couple other important issues, though. It's not just the rhythm control itself, right? So this is the RACE-3 trial, 250 patients with persistent AF with mild to moderate heart failure, either randomized to targeted therapy. And that targeted therapy was making sure that they received guideline-directed medical therapy, MRA, statins, ACE inhibitors, and ARBs, and cardiac rehab, compared to usual care. All of them underwent cardioversion for their persistent atrial fibrillation, and 2/3 had antiarrhythmic therapy. But you can see in the targeted therapy group in blue, in fact, you are more likely to be in sinus rhythm at the end of the trial, emphasizing in these patients who have undergone cardioversion, who have heart failure, there has to be careful attention to monitoring their other therapies and making sure that they're being optimally managed. I also show you the subgroup analyses, again, to show you that regardless of the subgroup, the directionality appeared to be the same, that all of these patients appeared to benefit from this aggressive management of their heart failure. Finally, I'd like to leave us with sort of the notion, can we prevent atrial fibrillation? And here is one trial that I've selected, and we can talk perhaps more in the panel discussion, of using the AHA LifeSimple 7 in the ERIC study. So the ERIC study was a generalized atherosclerosis risk and community study, took a very diverse group of 13,000 patients, and they were then evaluated by the AHA Simple 7. So these are the simple things, right? Stopping smoking, eating better, losing weight, getting active, managing the blood pressure, reducing sugar, and controlling the cholesterol. And you can see that if you had optimal control of these simple 7 factors, in fact, your likelihood of developing atrial fibrillation was lower. So I like to really think about focusing on upstream management. We electrophysiologists can only ablate so many patients with atrial fibrillation if that's what we end up doing. We really need to think more broadly in trying to prevent atrial fibrillation, and I think we can. So I'm going to finish up. We first talked about stroke risk, that DOACs are appropriate for most patients with valvular heart disease and those patients with who are frail. I also want to emphasize that we have to be holistic and think about these patients who have atrial fibrillation, that we can't simply give them the DOAC and say that our job is done. We have to manage their diabetes and high blood pressure. And when we think about management of their atrial fibrillation, in fact, early rhythm control appears to be fairly important, particularly in those patients with heart failure. I provided you some evidence about the importance of holistic care in these patients with established atrial fibrillation. And I hope I left you with the intriguing notion that maybe we can think about strategies to actually prevent atrial fibrillation in the future. And with that, I hope I haven't confused people, and I'll stop sharing. And I really appreciate the time. Thank you very much.
Thank you, Dr. Fred. Thank you very much for this wonderful presentation regarding the ECC. I will start with my questions to you regarding the heart failure. We have 3 types of heart failure. As you know that it's more common atrial fibrillation in heart failure, preserved ejection fraction, mid-range, and usually older and frail. So you didn't speak about this in your heart failure. You just speak about only heart failure with reduced. So I need your opinion about this. And when your advice to the audience, the guidelines to start what's the mean of early rhythm control.
Yeah, so a couple things. So let me take the first part first. I've actually just gave a lecture at the Heart Rhythm Society about the data sets in patients with rhythm control with preserved ejection fraction. They're all retrospective studies. There's no prospective study, but they're all fairly consistent. So there's a Japanese study using matched cohorts, which suggests that you have decreased hospitalization for heart failure in patients who receive a rhythm control strategy. We have large registry data from the United States, which in fact suggest improvement. In addition, we also know that, as you point out, atrial fibrillation is very common with our patients with preserved ejection fraction and often contribute to symptoms. In fact, atrial fibrillation is used as one of the sort of defining points of having someone with heart failure with preserved ejection fraction using Barry Borlaug's sort of risk score analysis. So I do think that actually aggressive management in these patients with preserved ejection fraction is actually important. The data is just less robust, although there is some that is coming out from EAST-AF. And finally, just to finish, because I don't want to dominate this discussion because there's so many good things to talk about here, and I'm looking forward to the other panelists' ideas and thoughts in this, is that when you look at EAST-AF, you know, there is no question that many patients received antiarrhythmic medications. And I do think that this notion of early management is important. We all know, though, that there are different kinds of early sort of presentations. So I just saw a patient in my clinic who had his first episode of AF at age 40. He got cardioverted. He's not had any since. Have I started him on an antiarrhythmic medication? No. You know, we'll just see if he has another event. We all have patients, though, that have lots of salvos of paroxysmal atrial fibrillation during a week. Well, that might be someone where aggressive early antiarrhythmic medication might be the appropriate thing, or even consideration for catheter ablation. There have been several studies that have looked at AF ablation as first-line therapy. Again, we don't really have time to talk about it, but the results are mixed, but generally suggest that if you're really going to eliminate the atrial fibrillation, you're going to be more likely to be successful with an ablation-based strategy. So I'll end it at that.
Okay. Hani or Lamia?
Go ahead, Dr. Lamy.
Go ahead, Dr. Hani, no problem. Thank you, Professor Kosumoto, for your nice presentation. I want to have one question I want to ask about you. As regard the recent guidelines for EF, do you think there will be a change in the guidelines, especially as regard the EF ablation? Because up till now, still EF ablation is a class 2 indication for paroxysmal EF as a first line and class 2B indication in congestive heart failure. Do you think there will be more evidence according to these recent guidelines like Stop EF First and CASTLE that it will be a class 2E at least in congestive heart failure and class 1 as a first line of therapy in paroxysmal EF?
Yeah, it's interesting. That's a great question. And I do think that, certainly there is a pressure, right, to elevate it from 2B to 2A. So for those of our audience who don't know, at least the ACC-AHA guidelines and also the most recent European guidelines suggest that it's a 2B recommendation for AF ablation in patients with heart failure. And really that was because CASTLE-AF was the only randomized trial that had looked at this. And the sub-analysis for Cabana was out, but again, not complete information on that. So that's part of it. But as Dr. Alam knows well, there is this fairly consistent data coming out. And I do think that it might be elevated. The problem, again, is going to be sort of the amount of data. And unfortunately, we don't have sort of a real randomized control trial to really look at sort of ablation per se as first-line therapy. Again, as I mentioned, EAST-AF-NET suggests that we should be far more aggressive than at least we have been in the United States, in managing these patients with atrial fibrillation. And oftentimes that will, require ablation. As you know, the studies are all consistent, though. When you look at maintenance of sinus rhythm, that ablation is far more successful than any antiarrhythmic medication. The studies, as you know, have all been incredibly consistent. So I suspect because of that, people are going to be more prone to recommend ablation.
Thank you.
Any?
Thank you. Thank you very much. That was a really illuminating presentation. Can you hear me?
Yeah. Okay.
Hello?
Go ahead. Yes, go ahead.
Can you hear me?
Yes.
The
problem is internet.
I think your voice is okay. It's just your video is bad. So you can go ahead and ask your question, I think.
Yeah. Okay. Can you hear me now? Can you hear me now?
Yes.
Go ahead. Go ahead.
Sorry about this. Yeah. I was always very surprised when trials comparing rate control to rhythm control showed no difference. Older trials. And, I would like to hear your insights about 2 points, which I'm concerned about. One of them is that they put all atrial fibrillation patients in one basket. It's a hugely heterogeneous group of people. Some of them are with a lot of comorbid conditions, and some of them are pretty healthy, not very many. And for us, it's extremely important to be able to identify who benefits. As we all know, there's no one treatment, one size fits all treatment. In Egypt, we have a real problem, Professor Kasumoto. We don't have any antiarrhythmic drugs except amiodarone. Recently, we have a generic dronedarone. We don't have, except Ritmonorm, whatever. It's type 3, what do you call it, Dr. Lamia?
Sotalol وamiodarone. Sotalol?
No, the Ritmonorm.
Class 1C,
Propafenone. So we don't have, most of the other drugs have been taken off the Egyptian market. They used to exist, but they're not here anymore. So for us, it's very difficult to control patients, whether to keep their heart rate down or to keep them in sinus rhythm if we cardiovert them. So ablation, I'm not an EPS person, but I advise it for most of my patients. But how can we identify the patients with atrial myopathy who are not going to have any atrial contraction, who are going to still need anticoagulation for the rest of their lives, even if they get successfully ablated on a surface ECG? It's just so difficult. This is my first question, and I have another one.
Yeah, that's a great question. I'll look forward to what Dr. Alam says. So a couple things. I do think that, you can generally use age as a stratifier, right? I do think that younger patients, and of course, now as I've gotten older, my definition of younger changes, constantly. It goes upward. But I'll see someone, let's say, who's in their late 70s who wants their ablation to be cured of their atrial fibrillation, but they have diabetes and high blood pressure and other things. I have to be honest with them. I'll talk to them about, look at, we might delay things a bit, but your notion of us being able to cure this, and will this change whether or not I would recommend for you to be, continue anticoagulation, is a completely, sort of different topic and subject. And your point is very well taken. Is it, AFib is this garbage basket EKG diagnosis, where you have this chaotic activity of the atrium. You, as an experienced clinician, know that they're very different. You have those patients who have one episode of persistent atrial fibrillation every 5 or 6 years. You have those patients who develop persistent AFib no matter what we do. We have patients who have 100 years, it seems like, of paroxysmal AFib, but never go to persistent. Why is that? So you're absolutely right that the underlying pathophysiology is so different. And actually, it's interesting. I know Dr. Alam will weigh in on this. When I was younger, I thought it was going to be some amazing technology that was going to get us out of this conundrum. But it really is not that. It really is when we can have that paradigm shift and identify what the mechanistic cause for the patient who has AFib in front of me or on my table and I'm doing a catheter ablation. That's when we're really going to be able to make a big difference, not some new technology that everyone is excited about. I am very, very struck by how different, atrial tissue is on my patients with atrial fibrillation. Some, even when they're older, it looks perfect. It's pristine. Others who are relatively young, where there's tons of scar, et cetera. And it's silly for us to think that one size fits all, that this pulmonary vein ablation, even though it's kind of been successful for a great majority of the patients, is the right thing for every patient. And so I think that's the issue. And to answer your first question, I will tell you, even in the United States, where we have a lot of antiarrhythmic medications, as I tell my patients, they're poisons with desirable side effects. They all have significant issues. And remember, our best medication, amiodarone, is only, 60 to 70% successful at a year, even with all sort of the complications, et cetera, associated with it. I'm the parent of, they're all old now, but if my child came to me and said, oh, I got a 60% on their test, I would be very unhappy, and so, we just have very poor medications.
Yes. Dr. Alam, would you like to reflect on that question?
Actually, I believe I agree with Dr. Kosomoto that the best thing for our patient nowadays is AF ablation, but the problem is the different underlying mechanisms that we surprised during the ablation. And I've met actually many young patients, 20s, in even less than 20, and has an atrial scar, even in cases of paroxysmal AF, and I don't know why. And old ages, 60s, and the atrium is small, and it is voltage map is completely clear. Still up to now, the BVI is the standard for the AF ablation, and I think the AF ablation is almost the best for our patient because we all faces side effects from the antiarrhythmic drugs, and most of these antiarrhythmic drugs is not suitable for our patients, especially with the abnormal structural heart disease. Actually, the only antiarrhythmic medication is amiodarone in abnormal heart structural heart disease, and actually more than 60% or 70% of the patient has side effects, most famous hypothyroidism, thyroid problems, interstitial pulmonary fibrosis, and so on. So I think the medicine or the management of AF will be changes every year according to the clinical trials, and I think the success rate or the AF ablation will be the main management, actually, versus the antiarrhythmic medication.
Hani, can we shift to another direction rather than?
Yeah, I have a question regarding anticoagulation. Yes.
Yes.
Dr. Kosomoto, When the late Bongani Mayosi, I don't know if you know him, he was South African, and he had started a trial on rivaroxaban in valvular AF. The protocol was written by both him and Professor Salim Youssef from Canada. And I contacted them, or maybe they contacted me, and to be an Egyptian PI. But when I looked at the protocol and realized at that time that they were going to include mitral stenosis patients without a prosthetic valve, and I've spent my life as an echocardiographer, I could see the spontaneous smoke in the left atrium, and I knew how difficult those patients were to anticoagulate. I suggested that they use the rivaroxaban dose of the pulmonary embolism, which is 15 milligram twice daily, because all our mitral stenosis patients were young patients with very little bleeding risk, very healthy otherwise, and incredible thrombotic risk. So when they insisted on the 20 milligram, I actually declined joining the trial at all, because I would not be able to get it through our Helsinki committee. I wouldn't feel comfortable about it myself. And I want to know your opinion about the dose of rivaroxaban 15. I mean, this dose, we use it every day in pulmonary embolism and DVT, 15 milligram twice daily. And then, for a few weeks, and then you shift the patient to maintenance dose, 20 or 15. So this dose is tested, and it's a safe dose. And you don't even do a renal calculation in those patients who have pulmonary embolism. We just give them 15 milligram twice daily, even if the kidney function is not that good, as long as it's not failing. So why are we sticking to doses which are for non-valvular AF and not using the pulmonary embolism dose in trials, especially for the patients with very low bleeding risk? Again, no one size fits all. And to be honest, rheumatic heart disease patients, in your talk, you said there's a small minority of valvular heart disease patients who wouldn't take NOACs. Not in Egypt, and not in India. There's a lot of rheumatic, severe mitral stenosis in Egypt. So your thoughts?
No, I think that there's some inconsistencies, right? And that's the problem with trial design. And that's the big, sort of issue is that, the problem with a clinical trial is that you get the most homogeneous population that you have, and then decide A versus B. We all know as physicians taking care of patients that oftentimes we don't get that sort of luxury. And so oftentimes, in fact, the patients that we see wouldn't necessarily be even represented in those trials. And we have to take our sort of best guess as it were to kind of make a decision on this. Your point is well taken about the rivaroxaban. Also, as you know, in the coronary disease population, lower, doses have been used in some of the coronary studies. You could make the same argument with Eliquis, apixaban, right? So, we use 5 twice daily for AF, but, 10 twice daily is used acutely. Yeah. So you're right. And the question then comes, for example, if I have a patient who has a stroke, let's say on 20 milligrams of rivaroxaban, sort of and we think it's embolic, what do I do? Do I try to go to a higher dose of rivaroxaban? Do I switch to warfarin or something else that I think is sort of better? Do I try some sort of left atrial appendage approach? Again, those are the kinds of questions that we all face as clinicians on a daily basis, which unfortunately there is no data. And unfortunately, I suspect you know the answer. There is going to be no data, on this in the future. And so we are going to have to take our best guesses going forward.
Yeah.
A final question to you regarding the frail. You have a slide for frail and using apixaban drug. Do you mean that this is the drug for frailty, for only WAC for frailty? You have 3 bars regarding pre-frail, frail, and full. How can you differentiate the first? Is it a drug for frailty? And what do you mean by that? As you mean that we are going to measure the frailty or just the age?
So great question. So Mohammed, cutting to the point. So actually in this analysis. In fact, they looked at all the DOACs, and generally, the most of the DOACs were non-inferior. This was one where sort of apixaban quote won, where in fact it was associated with sort of the best outcomes throughout. I do think that in a patient who is frail. And so I didn't put out the definition, but this used a standardized definition of frailty, which is really a lot of comorbid conditions, et cetera, beyond age. We all have patients who are 85 who are incredibly healthy, who we would consider non-frail and very robust. But we also have patients who are 70, for example, who are quite frail because of comorbidities, et cetera. So I can, if people are interested, I can provide the references there. It's a standardized multifactorial evaluation for frailty that really takes in a host of things, including, the ability to exercise and to walk, to sort of do activities of daily life and what those activities are, things like that. So they have their specific points. And so you get specific points, so you're frail. If you're close to it, then you're sort of pre-frail. And then if you're non-frail, if you're, sort of within the sort of the usual population. So that generally is how that works. I do think that, my issue, the thing that I like about all DOACs is the fact that the therapeutic window is far wider, right? With warfarin, it was at INR of 2 to 3. You're less than 2, it's not effective. You're greater than 3, you increase the risk of bleeding. And we all know about all of the interactions that happen. And that's the nice thing about DOACs just generally, right, is that the therapeutic window is wider. And because of that, they're a far better drug because they can take care of all the changes that and vagaries that happen in real life to all of our patients. And so I think we as physicians ought to feel more comfortable being able to prescribe those medications compared to warfarin.
Okay, thank you very much. I think we finished this talk regarding atrial fibrillation, heart failure, prevention heart failure, valvular disease, left atrial thrombi, prevention of strokes. You have a lot. With a lot of trials. Thank you very much. Now we're looking for the next, so just think it's more appealing. Diagnosis of atrial fibrillation wearables and subclinical AF. I heard this from you before, that's why I like it. I need your the Egyptian guide and all of the Middle East to look for this important talk.
Well, thank you, Mohammed. It's very kind of you to remember this talk. It's actually my favorite talk to give because I think that this is actually the new paradigm of how we're going to deliver care in the world actually going forward. So it's wearables and subclinical atrial fibrillation. And again, I have no financial relationships with industry at all, and there's going to be no off-label usage here. So I generally like to start most of my talks, other than those sorts of update talks that I just gave, with a case, because I think that's important for putting things into clinical context. So this is a real patient, 73-year-old gentleman who has palpitations for the last several months. Palpitations are irregular, slightly faster heart rate that he complains of. He's otherwise very, very healthy and quite fit. And he underwent ambulatory monitoring. And here's first his ECG, and we'll come back to it. Here you can see the sinus rhythm and a few premature atrial contractions. And here's the monitor. It was incredibly boring. 30 days, and there was literally nothing. I mean, he had sinus rhythm, a few PACs here and there, but really nothing. So we'll go back to that case, but let's now talk about screening for atrial fibrillation. I'd like to spend a moment talking about the evidence base, or at least the amount that I can cover in these 15 minutes. I'd like to talk about new tools and strategies. And then finally, what's going to be important for your audience, right, is what is actionable? What can we then change what do we see that can then change the way we manage the patient? So let's start with the evidence base first. So the one study I'd like to highlight was just presented at ACC this past year, and this is the Stroke Stop study. Now, remember that Stroke Stop was a cross-sectional study taking all patients 75 or 76 years of age in 2 counties in Sweden, Stockholm or Halland County, and they were randomized in a 1-to-1 fashion to either not screened or prospectively screened. And they presented some of their original data in 2015 on kind of what happened sort of with the screening. Now, it's important to know what the screening was. So that's shown in blue. So basically, they they had a monitor that they could use on sort of on an as-needed basis that they had for a couple weeks. It's also important for us to know what their AF definition was. Their definition was at least one 30-second recording with an irregular rhythm without P waves, or two similar episodes lasting 10 to 29 seconds. And that's going to be important when we talk about sort of actionability in the future. Here then is from the slide that was presented at ACC. So you can see then a large study with nearly 14,000 in both groups with a minimum of 5.6-year follow-up. And here then is the endpoint of screening versus control. You can see the lines are pretty much superimposable, but begin to potentially separate at about year 7. And it did just barely meet statistical significance for the primary endpoint. It was a combined endpoint of ischemic stroke, systemic embolism, hemorrhagic stroke, hospitalization for bleeding, etc. Before I move on from this, I'd like us to think at least about what I call screening mathematics. So let's say you had a hypothetical test with a 5% prevalence, a 95% sensitivity, and a 95% specificity. So, on the basis of most of the tests we use in medicine, this is a pretty doggone good test. And here then you can see the false positives, right, and the true positives, either in pink for the true positives or blue for the false positives. And you can in fact see that they are essentially equal, that the false positives equal the true positives. So if we had this test, this is the problem with screening tests, that if we do this screening, we have to be ready for a lot of false positives and potentially unnecessary testing. So for this, I want to say, okay, for screening, we'll identify AFib. In other words, the more you look, the more you'll find. And for cost effectiveness for large populations, I put a big question mark there because I do think that it's important for us to acknowledge that you will find lots of false positives with a large sort of non-opportunistic strategy. How about new tools and strategies? Let's go back to this ECG. You can see the sinus rhythm and in this 12-second recording, a few premature atrial contractions. And what's important for us to know, I think, comes from this study. So this was the AF-ESUS sub-study. So remember, ESUS is embolic stroke of unknown source. And of these 853 patients, they then underwent this continued evaluation for atrial fibrillation. And what was interesting is that you can see when you looked at those patients who had no supraventricular ectopy shown in purple, compared to those patients, who in blue, compared to those patients who had just 2 premature atrial contractions or greater shown in purple, in fact, your likelihood of having then a stroke or developing atrial fibrillation or even death appeared to be higher if you had just premature atrial contractions on an ECG. So I actually use that. Then if I see a fair number of premature atrial contractions on just a baseline screening ECG, I'll think, to myself, is this a patient with a lot of stroke risk factors? And is this someone who then I should look further, either with an event monitor or with a Holter monitor? And if you use an event monitor, there are many studies that have looked at this. I use the ASSERT study here. In this sub-analysis or this additional study of ASSERT, 260 patients greater than or equal to 65 years of age who also had to have something else. They had to have a CHA2DS2-VASc greater than 2 or some sleep apnea. And in addition, also had to have left atrial enlargement or an elevated NT-proBNP, which is being used as a marker for the detection of atrial fibrillation in the ABC and other trials. All of these patients received an implantable cardiac monitor. And you can see that if you look at subclinical atrial fibrillation, or SCAF, defined as greater than or equal to 5 minutes, shown in black here, there is a significant incidence, that was detected certainly by 3 months and would continue to increase. But not surprisingly, if you define the SCAF as for longer episodes, for example, for blue, for greater than or equal to 24 hours, again, this will be important when we think about what's actionable. In fact, the yield was far lower. But the bottom line is, the longer you look, the more you'll find. But generally, the high yield stuff is usually usually within the first 3 months, but does continue to increase, again, depending on your definition of what you're looking for and what you see as relevant. One of the things that our group has looked at, Zaki Adia up at Mayo Clinic Rochester has led this, is using an AI algorithm, right? So maybe AI or artificial intelligence can identify things that we as clinicians don't see. P-wave shape or premature atrial contractions, QRS changes, whatever the case may be. And when we have an ECG here in my place, we can then apply the AI algorithm. And so you can see that down below for this particular ECG. It's really good at predicting whether you're a man or a woman. So 100% that it's a man. It's actually very useful for predicting low ejection fraction. And in this case, the percentage of AF predicted by the AI algorithm was 19%. And Peter Noseworthy has looked at this a little bit further. And when you look at the likelihood of developing atrial fibrillation in the future, the AI algorithm is pretty good. So in other words, if the AI algorithm says that you have a likelihood greater than 12.4%, shown in red here, of having atrial fibrillation, even if no AFib is identified at the time of the ECG, then when you then follow those patients outward, let's say 9-10 years out, a full 35 to 40% of those will actually have developed atrial fibrillation. So in these patients, can we get on them early, get them to lose weight, do things like this that might reduce the likelihood of them developing atrial fibrillation in the future? It really is an interesting way to sort of think about things. We all know about wearables. I show you on the left Norman Holter with the original Holter monitor, which was this huge, essentially 100-pound backpack. You see the monitor that then was popular in the 60s and 70s, but now in the 2000s, everyone seems to have an iWatch where they can get an ECG. And I show you the Huawei Heart Study, which showed data similar to the Apple Heart Study, just because it's relatively recent. Guo and colleagues took nearly 200,000 patients with a PPG, so using plethysmography, to then look for atrial fibrillation using their algorithm. Of this group of patients, a small number of them received notification of an irregular pulse, and of these, about half of them had confirmed atrial fibrillation. As I show in the red arrow, no surprise, your yield was far higher in those patients who were greater than or equal to 65 years of age, either with suspected atrial fibrillation by the wearable or with identified atrial fibrillation, the AFib further confirmed by an event monitor. So again, when we think about using these wearables and this data, again, thinking about pretest probability is going to be critical. But I don't know what it is in Egypt, but in the United States, just about everyone seems to have some sort of wearable. And here I show you some of the data that the horse is out of the barn, as it were, using the old US phrase, that boy, wearables are going to become that much more popular over time. And this was going to lead to a paradigm shift where we are used to having the patients come to us with symptoms and then we give them a diagnostic test. They are now going to be coming to us with data. And it's not just going to be over rhythm. Rhythm was the easiest thing to do, but it's also blood pressure, glucose, oxygen, temperature, PA pressures, etc. In addition, thinking beyond wearables, people are working on using sweat and saliva and actually these biologic tattoos. So people don't have to wear watches. They can get these specialized tattoos that will do these measurements. We're thinking about measuring things from within. How about measuring from without? The environment, temperature, pollution, et cetera, COVID exposure that is occurring now, right? And how about then linking these devices? Can these devices then be linked then to healthcare providers, measurements to notification? In the US, it would be this 911. Can the device then identify ventricular fibrillation in the future? And thus check, are you okay? And if there's no response, yes, maybe then have the ambulance be dispatched to that area to reduce the time that is present between someone's VF arrest and then being resuscitated. Again, I want people to think beyond sort of wearables and what might this look like in the future. So, higher yield in older patients, regardless of what strategy we use, whether it be wearables, AI, et cetera. it's more than AF. I want this audience, your audience, to think sort of more broadly. And importantly, this is going to lead to an important paradigm shift in healthcare delivery. Again, now patients are going to be coming to us with data that we are then going to have to define and identify. So I'd like to spend the last few minutes about talking about sort of what's actionable in this information. And it really gets first down to sort of how much AF is too much. So I show you studies, most trends, and ASSERT. Now, these are pacemaker studies that have looked at patients with sinus node dysfunction and in other populations. And they found that relatively short periods of time, at least in most in the initial analysis of ASSERT, seem to be associated with a higher risk of stroke. However, when the ASSERT group looked at their data a little bit more closely, in fact, they found that really when you look at the likelihood of stroke and CNS events, it seemed to be far higher in those patients who are greater than or equal to 24 hours. Their episodes are longer than 24 hours. So it seems to be very, very important. And the problem that we run into, right, it's anticoagulation or not. It's damned if you do, damned if you don't. In other words, are you going to now tell this patient, I am now going to start you on anticoagulation for the rest of your life? And that is a hard decision. And so what should we do? Rod Passman has done some lovely analysis looking at the dependence of the CHADS VAS score relative to the amount of time that the patient has of atrial fibrillation. And this is what I do. And we can talk about it in the panel discussion. Obviously, if someone has a very, very high CHADS VAS score, or if their AF episode is greater than or equal to 24 hours, I think the data is pretty good to anticoagulate. So that's the red in the bottom right corner. If their CHADS VAS score, and I use the sex-independent CHADS VAS score, right, because that's what we're using these days, no anticoagulation and very, very short episodes, then no anticoagulation shown in green. And it's that area in the yellow where I'll use sort of the duration of the subclinical atrial fibrillation along with the patient's risk factors for stroke to then make a decision on when to pull the trigger to begin to anticoagulate, somewhere in that middle area in yellow. And I think it's important for people on this webinar to realize that it's important to continue to observe for AF development because AF does then potentially occur over time. I think it's important to reassess for progression, that you just can't take a static measurement and use that, apply that a year from now or 2 years from now, that you have to continue to look at this. And maybe we'll have time in the panel discussion to talk about other stroke risk factors, you know, cigarette smoking, other factors which potentially contribute to the CHADS VAS score to then increase someone's risk for stroke. So what do people recommend for screening? So it's interesting, the most recent 2020 guidelines suggested that opportunistic screening is class 1 for identifying patients with atrial fibrillation with that are older than greater than 6 to 5. And this is just checking their pulse. I'm okay with this being a class 1 recommendation because, you know, we all ought to check our patient's pulse when they come in for a physical examination. On the other hand, you know, they gave a 2-way recommendation for systemic ECG screening for those patients greater than 75. And I don't know if I'm a country such as Egypt or here in the United States, whether or not that is really applicable. And I would have some arguments sort of with that based on what I spoke to you about. And in fact, that's why in the ACC/AHA HRS guidelines, there's no comment. And in fact, the U.S. Preventative Service Task Force, the USPSTF, which is tasked with looking at screening, in fact, suggested that there is insufficient evidence here at this point in time for mass screening. And really, a lot of this comes down to unintended consequences of mass mandated screening. So what happened with my patient? He's an engineer. So he built his own wearable. It's amazing. And he detected atrial fibrillation. Look at the fidelity of this ECG. He got a repeat event monitor, which showed 3 episodes, 10 minutes, 30 minutes, 18 hours. We discussed the CHADS VAS score. You know, he's a CHADS VAS that's sex independent of 1, almost 2, right? Because he's 73 years of age. And do we really think that suddenly when someone becomes 75 years of age, they suddenly have this increased risk for stroke. And after a discussion together, he elected to start on dronedarone for his symptoms and apixaban for his stroke risk. So let me conclude by summarizing. We first talked about the evidence base. Screening will identify AFib. In other words, the more you look, the more you'll find. But there is a big question, at least in my mind, about how cost-effective this is for a large population. I'm very excited about new tools and strategies, but we're going to have to use them carefully to ensure that we don't have unintended consequences of inappropriate testing. Not surprisingly, there's going to be a higher yield in older patients, and those are the patients that I think we should screen because then it's going to potentially be actionable. I think that it'll be more than atrial fibrillation in the future, and it's going to be a paradigm shift in healthcare delivery. And finally, for now, what do I recommend? Well, generally, longer is proportional to worse. So 24 hours is my cutoff, but if it's 22 or 23 hours, I tell them, look, it's not that different than 24, and it's a continuous increase. I think it's important for us to consider that holistic patient evaluation. So it's not just the duration or the identification of atrial fibrillation. It's also thinking about that patient and what their stroke risk factors are before we then make a decision together about whether or not to anticoagulate. And with that, I know it's time. I've spent too long, but again, my favorite topic, and I look forward to the discussion here amongst the panelists. Thank you.
Thank you, Fred. I will start my question. I looked for this before, and then I read a lot about, and I'm interested in what's about that. Let's call it data mining and artificial intelligence. Do you think this is the time, because already you can put the data in your iCloud, and you put an ECG, and then you look at this patient is an event for atrial fibrillation, and you can suspect that this patient will develop AF or he's going to have an AF, and then start your treatment rather than doing the approach and all the techniques, which is sometimes very expensive. It's not applicable in all countries. How do you think that we can use the technology nowadays for the iCloud, for the artificial intelligence and data mining?
Mohammed, I think that's a great question. I actually think AI is going to be incredibly valuable because what's going to happen sort of with this is a tool. It's not right all the time. I have another sort of piece talking about sort of when is AI wrong? But what is important about this is in any resource-constrained organization, or country or whatever, we are resource-constrained. What I think this allows us to do is identify a group of patients where our yield will potentially be higher, where we would then, if we were to find it, would then there be potential consequences, let's say a stroke, for example, or that we would then change our management to start anticoagulation. So should we do it willy-nilly? Absolutely not. Should we think about applying this in selected populations? Yeah, I actually think we're really close to that. And here at my place, in fact, that's what we're starting to do. So that if, let's say, you have this 70-year-old who has lots of premature atrial contractions, just for argument's sake, but has never had atrial fibrillation, but has high risk for stroke because they have hypertension or diabetes. Yeah, I think that this is now ready for prime time, that in fact, if the AI algorithm says that you have a high likelihood of AFib, would I then say, look, it's probably worth it to do a 30-day monitor to kind of look at this, or for you to potentially buy a wearable to then look for peaks in heart rates? I think that that's okay. I think that would sort of push me one direction sort of or the other. Or conversely, let's say the AI suggests that it's incredibly low. Well, and maybe, it's not perfect. We'll take everything into consideration, but maybe we don't have to be as aggressive in looking for things. So I think that it's going to help us rather than hurt us if used in the correct way.
Okay. Hani or Lamia?
I will ask first because I actually have to leave and go to another meeting where I have to give a presentation. I'm fascinated by the wearables, and let me tell you a quick funny story. I actually bought 10 AliveCor devices before even the Apple Watch was released, and I bought 10 cheap Android phones, and I stuck them on the back of them, and I was giving them to my patients free of charge as sort of monitors. And, the yield, I only gave them to the patients whom I thought had something, and I would let them keep them for a month or two, and the yield was amazing. I wish I'd written a paper about it. And I believe that this is the future. I mean, the future will be wearables and AI. And I don't think I've enjoyed the presentation more than this presentation that you just gave in a long time. My question is, can we improve on that? Like have the wearables give an automatic CHA2DS2-VOSC score to patients who are elderly, because you don't want to be overwhelmed by anxious 28-year-old people, but you do want the patients who are actually wearing those, who are at high risk, to know that they're at high risk. And we don't want to be flooded by millions of people whose watches have told them that their blood pressure is high or temperature high or arrhythmia high. So how far do you think we're going to go with this, algorithms to help patients decide their own risk?
Hani, that's incredibly perceptive, because I absolutely agree with you, because I think what happens, right? Remember what I was talking about earlier, what you're talking about here in your patients is pretest probability. And with that pretest probability of finding something that's going to be actionable, we've talked about physical measurements, right? There is no question that by incorporating electronic medical record data into this type of information, that you betcha this sort of thing, I think, is going to be combined. And, who knows, as you know, from the ABC data, BNP, other sorts of things that they might happen to get for something else that could then be incorporated into this to then provide even further sort of evaluation or a more accurate guess as to whether or not they have atrial fibrillation or not, or that they have something that would be then manageable or actionable. So I absolutely agree with you. And I'm sad that you didn't write that up, because I think that that's the kind of information that we as physicians have to really embrace, because this is a really exciting way for us to manage our patients. And in fact, as you were talking about it, reminded me back many, many years ago at a Heart Rhythm Society, about 10 years ago, when the AliveCor had just come out, they gave us the AliveCor pieces. And so we were on the streets of Denver grabbing people like, just sort of randomly to have them get their EKG and to show them what it could do. And I love that you took things into your own hands and did it for your high-risk patients, because I think that that's right.
Thank you.
Lamia? Unmute. You are on mute.
I'm sorry. As regards patients with high burden premature atrial extrasystole, you said that it may be a marker for AF progression and the development of AF over years. Is there any role for medication to suppress BECs, especially in selected patients with high risk of AF, to suppress these prematures and to decrease the incidence of firing of these foci to develop AF? Like beta blockers, calcium channel blockers? Is there any role for this medication, especially for symptomatic patients with these prematures?
Yeah, so that's a great question. Actually, interestingly, the Copenhagen complex atrialectopy data show that if you had lots of things, on a Holter monitor, which I didn't show that data, in fact, also confirmed this sort of information. And it makes sense. Of course, I will say that suppressing PVCs after myocardial infarction in CAST also made sense back, 35 years ago. So we're treating a marker rather than a actual endpoint. So I am concerned potentially about that. It's no different than, we have aggressive ablationists here, and we can talk about this if it were to ever come up, where someone's asymptomatic with a normal LV function who has PVCs. Well, yes, there is this likelihood of you developing a cardiomyopathy in the future, but should I then do a preventative PVC ablation for something that if we were to do in the future when you had the cardiomyopathy would be reversible? I don't know. Now, your point is well taken, because, it's one thing to have a reversible cardiomyopathy, but it's another thing to potentially have an irreversible stroke. And so that's then the difference between, sort of those analogies. And, certainly I don't do it now. I will say, though, that when patients have significant premature atrial contractions, as I mentioned, I will look a little bit more carefully. I will have them follow up with us a little bit more carefully. I'll have them check their pulse. I'm not as generous as Hani. I tell them to get a smartphone and, maybe check their, sort of heartbeats sort of with that and hope that a stroke isn't their first presentation. But I do think that these are patients. I don't know about suppressing it, but I do think clearly warrant a more aggressive sort of observation.
Yes. Thank you.
Okay, finally, can we have your slide regarding the subclinical atrial fibrillation? You said that we have to stop at this. And I saw also with us Dr. Ahmad Mukhtar is an EPS man. He can join us for this slide and he can ask his question. No, not this one. Slide. You have a slide, Dr. Fred? Yeah, for your screen.
I do. I didn't want to interrupt anything, so.
Can you stop this one? Aikum? This one. Please come back to Dr. Fred slides. This is only. Can you share your screen? You have only one slide. Yes. Please. We have to stop this one. Yeah. Regarding the EHRA duration and the subclinical atrial fibrillation. This is an important.
Yeah. So let me go back.
We have to discuss at the panelists. Ahmad Mukhtar, what's your idea of this slide? Go ahead.
This one or the other one? I have both.
No, the other one. The one with the acute heart rate episodes and the risk factors.
The other one.
Yes, this one. No, hold on. I'm getting it.
Back.
Not this one?
No. Back.
No, these are not.
The EHRA duration.
The acute heart rate episodes and the risk factors.
Perfect. Yes, I will. Yes. It's forward. Let me show that to you. Yes, absolutely. Let me do that. Give you that. This one.
Yes, just it. Yes.
Yes, what?
I'm really.
Do you think this should be the future? Ahmed.
Yes, Dr. Sobhi. Yes, I have a question for Dr. Fred.
Yes.
Patient implanted dual chamber pacemaker. We oftenly during just routine follow-up find acute heart rate episodes. Some patients like female over 75, which had a shared vascular score 3 or more, have just 2 or 3 episodes over 1 year of acute heart rate episodes for very short duration, 2 or 3 seconds. You would anticoagulate this patient based on this chart?
Great. So because it was short, it would still be in that yellow version, right? So it'd be the kind of thing that we would talk to the patient about because, here's the deal. So, I still tell this quaint story to my patients because it's easy to say. You get atrial fibrillation, you have, atrial stasis, you have spontaneous contrast, as Dr. Nagy pointed out, and you have, sort of left atrial, thrombus that builds up mostly in the appendage and the little nooks and crannies. But if you look at the data pretty carefully, the temporal relationship with an AF event and a stroke is very, very bad. They're almost independent. So in other words, if you thought that they were related, the AF durations were related to the stroke event, you would think that there'd be some sort of relationship. That hasn't been the case whether you look at ASSERT or the TREND study. So that brings up the notion that is the AF not necessarily a causal piece, but actually just an associated risk factor for the atrial myopathy, as Mohammed brought up earlier. So, it's a lot more complex than that, and it's again one of those things where it's a lot of discussion, or maybe fortunately, between you and your patient, because you can't undo a stroke. But there is unquestionably complications associated with therapy. We are lucky, though, using the DOACs, in particular apixaban. Even though I know Pfizer sponsored this, I can say this. I mean, they're the only study that's the only drug that you had Averroes with, where you took patients who were not candidates for anticoagulation and then randomized them either to aspirin or apixaban. And in fact, the bleeding risk was about the same. So, and certainly there was improvement in stroke with the use of apixaban. So, again, for the patient that you brought up who has a ton of stroke risk factors, you would worry about it. Now, having said that, though, in Navigate ESUS and several of the other trials where they would give empiric anticoagulation, in fact, it was not associated with, in fact, a benefit. Those studies have all shown that you really have to identify, again, a real causal reason for, in that case, an embolic stroke of unknown source, which is different than the patient that you're talking about. But again, this would be the patient that I would begin to worry about. If it was really only seconds, I think you could be okay holding off on it per se, because it really, all of the post hoc analyses of all the pacemaker studies really used a cutoff of anywhere from 5 minutes to 6 minutes is sort of the lower end, whether it be in MOST or ASSERT respectively. So I think with seconds, you would be on pretty thin ground. But if it was 6 minutes or more, right, then I think starting to talk about that anticoagulation might be appropriate. That's just my opinion. And again, it's really something that I think we as clinicians just have to discuss carefully with our patients.
Okay. So finally, any comments on this slide, please? Because you have to go to another talk. Any comments about this? Dr. Lamia, Dr. Hani, Dr. Ahmed Mukhtar, Dr. Kusumoto?
I think the benefit is clear when we have a very high burden of acute heart rate episodes and the high risk scores. But other scenarios, those with low score or those with short duration, it's unclear the benefit of initiation of anticoagulation in this situation. We have to document atrial fibrillation clinically before starting anticoagulation, I think.
And I think that's generally true. Absolutely. And so, I mean, when you look at patients with a CHA2DS2-VASc of 1, where you may or may not anticoagulate, that's then, remember, it's a 2B recommendation, at least in the US guidelines, more aggressive in some of the other countries' guidelines. It's really one where I'll potentially look at other things that might clue me in that I think that their risk is certainly higher. But I agree with you, that there's a big difference between an atrial high rate episode and AFib.
Okay, thank you very much, Dr. Kusumoto, for these also wonderful lectures. And I ask you to be with us till then, please. Thank you very much for all discussions. Let's go on to Dr. Said Farag, Professor of Cardiology at Zagazig University. He's going to have a case of a non-ST MI with GIT bleeding, which is very common in our scenarios every day. Dr. Said, the floor is yours.
Okay, you hear us? You hear me?
But yes.
Okay. Thank you, Professor Sobhi and CVREP for inviting me for this actually elegant educative meeting. And I think, as you mentioned, Professor Sobhi, it is one of the challenging cases. And I think if any of us meet it, I think it will be very challenging and need. My dear professor and colleagues, I'd like again to thank Professor Sobhi and the CVREP for inviting me for this very and highly educative program. And also I have the pleasure and honor to be with such prestigious faculty. As I mentioned, this is a case of non-segment elevation, acute coronary syndrome, and upper GI bleeding. I think it is a challenge we sometimes meet, and we have to have an integrated, multidisciplinary, evidence-based strategic management. And I'd like to start first with this very important slide from the European Society of Cardiology, which is actually state to us that the bleeding risk is actually by itself the ischemic and thrombotic risk, because if we had the risk factors for bleeding and we had a major bleeding, we might be obliged to stop the anticoagulation and or antiplatelet, which leads to prothrombotic state and, of course, myocardial infarction, stroke, VTE, and cardiovascular death. Also, the major bleeding can oblige us to do it's a blood transfusion, which is inflammatory and oxidative stress, which leads to plaque rupture and again, myocardial infarction and thrombotic complications. Also, the shock and severe anemia per itself can lead to myocardial ischemia with all its consequences. Now, let us dive in our case today, which was a male patient, 76 years old, hypertensive, diabetic, ex-smoker, and known to have atrial fibrillation under bisoprolol 5 mg, valsartan 160 mg plus amlodipine, rivaroxaban 20 mg, and atorvastatin 40 mg, with frequent use of non-steroidal anti-inflammatory drugs because of bilateral knee osteoarthritis. He was brought to the ER by an ambulance team after fainting, preceded by severe chest pain. He was in pallor, sweating, and his blood pressure was 70/50, so he is almost in shock. Measurement taken by the ambulance staff, heart rate 110 beat per minute, which was irregular because of atrial fibrillation. Saturation at the ambient air at the time was 96%. And the ECG, which was done immediately, ST segment depression, V1 to V6 plus atrial fibrillation, immediately transferred to the CCU to be supported by the intravenous noradrenaline and fluid support. Bedside echocardiography revealed the hypokinesia of anterior wall segment with ejection fraction 56 with mild mitral regurgitation, elevated troponin, hemoglobin was 12, and serum creatinine was normal. Immediately given aspirin 300 mg, a low molecular weight heparin also given in a dose of 0.5 mg per kg IV, and transported immediately to the cath lab. And I'd like to give you the evidence for this transportation to the cath lab, because from the latest guideline of acute coronary syndrome non-segment elevation, for these patients with hemodynamic instability or cardiogenic shock with such a situation like ECG of ischemia, chest pain, and elevated troponin, we have immediately to push him to the cath lab within 2 hours, and this was the evidence for that. Also, from the same guidelines, we have some factors which you have to mention here for bleeding risk factors like hypertension, abdominal liver function, stroke or intracranial hemorrhage history, bleeding history of bleeding diathesis, with anemia and reduced hemoglobin, lipile, INR if on vitamin K antagonist, elderly more than 65, and actually our patient is more than 75, concomitant drugs like NSAIDs, and also our patients was kept on non-steroidal anti-inflammatory because of osteoarthritis. Also, it is worthy to mention here that the strategies to reduce bleeding associated with PCI, which is the radial artery access, as we all know, to reduce, of course, the vascular access site bleeding, the BBI in patients taking that who are increased risk of bleeding, especially those elderly patients, non-administration of unfractionated heparin in patient with vitamin K antagonist if the INR more than 2.5, and this is important to mention. Another very important statement here to mention is the pre-treatment with aspirin only, and add the P2Y12 inhibitor when coronary anatomy is known or efistemi, and this is what we did in our case. We load the patient with aspirin and low molecular weight heparin only, and we kept the P2Y12 inhibitor until we revealed the coronary anatomy. The GB2/3 inhibitors, of course, for bailout or peri-procedural complication. And of course, we have to consider the shorter duration of combined antithrombotic therapy. And this is a very important strategic point, because this is the whole issue for keeping the balance in such a high-risk patient of bleeding between bleeding and ischemic complications. Let's back to our patient again. The patient, as I mentioned, pushed to the cath lab, and the transradial coronary angiography revealed osteal-tight LED 95% lesion with multiple non-significant atherosclerotic plaque in the LCX and RCA. The patient loaded immediately with 180 milligram ticagrelor and PCI was performed with current generation drug-eluting stents. And here is important to mention that the current generation drug-eluting stents, that what we used, with improvement of the patient's clinical condition, of course, because of the correction of the osteal-tight LED lesion, which is the cause of his chest pain and the shock state. Unfortunately, day after the coronary angiography and PCI, the patient gave a plaque stool with little amount single attack of fresh blood. At that time, the gastric tube was inserted and the gastroenterologist was immediately consulted. He recommended crossing the blood and ordering 2 blood units to be ready for the situation, qualified the patient for endoscopy, and at that time, the hemoglobin level were rechecked and it was 11, and we can notice here that the hemoglobin is reduced by only 1 gram from 12 to 11, and remember this figure, please. Here is also an important algorithm for those patients with active bleeding if they are under NOAC or vitamin K antagonists. And so far, our patient was under NOAC, and the bleeding is considered to be from mild to moderate bleeding, because it's single little amount of fresh blood. So we can do a symptomatic treatment, fluid replacement. We can consider blood transfusion if needed. And as the gastroenterologist recommend to prepare the patient for gastroscopy, sometimes we consider to add oral charcoal if recently ingested NOAC for those patients. Sometimes if severe or life-threatening bleeding, we can consider the antidote for the NOAC. And here to mention that the idarucizumab for dabigatran and the andexanet for the rivaroxaban or apixaban. Here is a very important algorithm for antithrombotic treatment management of acute bleeding after acute coronary syndrome. And of course, here we have to mention if this active bleeding leads to hospitalization or not, because if needs to hospitalize the patient because of hemodynamic deterioration, this is mean that is life-threatening bleeding or severe bleeding. And if the hemoglobin loss is more than 5 milligrams, of course, considered severe bleeding. If less than 5, it's considered to be moderate bleeding. And if it is the blood loss is considered for hemoglobin more than 3 grams, also considered moderate to severe bleeding, mild to moderate bleeding. And if it's less than 3, it is considered mild bleeding. For our patient, as I mentioned before, the hemoglobin loss was 1 gram, so it is considered mild bleeding. For those patients with mild bleeding, we can continue DAP and we can continue oral anticoagulation with some modification, because this patient was loaded with ticagrelor, and accordingly, because of this mild bleeding or because of this gastrointestinal bleeding, we have to switch from tica to clopidogrel. And also we have to consider, if we will resume oral anticoagulation, we have to choose those with lowest bleeding complication and with the lowest effective dose. Of course, it is worthy here to mention that for those patients with life-threatening, with severe bleeding, we have to stop, of course, the antithrombotic medications. Sometimes we can continue a single antiplatelet drug till we reveal and to stop the upper GIT bleeding and reassess the situation. Then we can consider resuming the dual antiplatelet accordingly. And maybe after 1 week from stabilization of the case for those patients with significant bleeding, we can consider resuming the oral anticoagulation. Here is also another important slide for those patients with acute upper GIT hemorrhage in patients using antiplatelet therapy. Upper GI endoscopy, of course, here is mandatory, and this is what ordered by our colleague, the gastroenterologist, especially for those non-varicose source of bleeding, like peptic ulcer bleeding. Here is what's called the high risk and low risk stigmata by the upper GI endoscopy, and what's called the Forrest classification. And we have here the Forrest classification 1A, 1B, 2A, 2B, and for low risk 2C and 3. Those Forrest classification is worthy to be mentioned by the gastroenterologist and is worthy to be known during the integrated management, because it will affect our decision for resuming and continuing either on a single antiplatelet, dual antiplatelet, or resuming also and continuing the oral anticoagulation. And if we have a look here to the this forest classification, a class 1E is a spurring hemorrhage, actual hemorrhage present. 1B is oozing hemorrhage. 2A is non-bleeding visible vessel. 2B is an adherent clot. 2C is a flat pigmented spot, which is considered low risk, and 3, which is clean base ulcer, which is the low risk also for endoscopic stigmata. Another important point here, which is the continuing and restarting NOAC. We have to consider factors favoring withholding or restarting the anticoagulation. And those factors are unidentifiable site of bleeding is important, multiple angiodysplasias in the GI tract, no reversible treatable cause, bleeding during treatment interruption, chronic alcohol abuse, need for dual antiplatelet therapy, and older age. All these factors are affecting the decision for assessment for withholding or resuming the oral anticoagulation. And if the net assessment in favor of withholding anticoagulation according to this multidisciplinary decision, we have to consider no anticoagulation versus a left atrial appendage occlusion. If not, we can reinitiate oral anticoagulation as early as feasible after 4 to 7 days. But here, a very important statement under this statement also. If patient is more than 75 years, like our patient, we have to consider NOAC other than dabigatran, rivaroxaban, or higher dose of edoxaban, because those are carrying a much more higher risk for bleeding in such age group, which is more than 75, like our patient. And of course, here the guidelines stated that in AF patients eligible for NOAC, it is recommended to use NOAC in preference to vitamin K antagonists in combination with antiplatelet therapy. So we have +1 recommendation here for preference of NOAC. This is a very important trial, which I actually attended in the ECC Congress in 2012, which was in Munich. And I think this trial was a landmark trial for changing and for affecting our practice, which is the WAISE trial. The WAISE trial for patients on oral anticoagulation therapy due to atrial fibrillation or mechanical heart valve undergoing PCI were randomized either to clopidogrel alone or to aspirin and clopidogrel. And actually, the conclusion there was among patients on oral anticoagulation therapy undergoing PCI, the use of clopidogrel alone compared with aspirin plus clopidogrel reduced the frequency of all bleeding events. And this is actually in those patients affecting our treatment strategy at that time. This was accomplished without an increase, which is also important, without an increase in the adverse ischemic events, as we see here in this graph. Also, the evidence is going on, and here we can notice that the stroke or systemic embolization, it is in favor of NOAC over warfarin, and the major bleeding again here is in favor for NOAC over the warfarin, and this is from the different meta-analysis for different types of NOACs. And here we have a lot of evidences which came up to the stage in the last years from 2060 for those important subsets of patients, such as our patients which is using the NOACs in AF plus acute coronary syndrome, like Pioneer for rivaroxaban, Vidual PCI for dabigatran, and Augustus PCI for apixaban, and Interest for edoxaban. And in patients with AF and ECS or PCI on P2Y12 inhibitor, apixaban is at least not inferior and possibly superior to vitamin K antagonist for major or clinically relevant non-major bleeding. Single antiplatelet therapy with P2Y12 inhibitor, here the evidence is reconfirmed, and the Augustus is superior to dual antiplatelet therapy with a P2Y12 inhibitor and aspirin for the major bleeding in patients on oral anticoagulation. And so for that, the Augustus came to the stage with 2x2 factorial randomization for apixaban 5 milligram aspirin placebo, vitamin K aspirin placebo, and the primary outcome was the bleedings, major bleeding, and secondary outcome was this hospitalization, death, and ischemic events. And it came up with a very important conclusion that a major or clinically relevant non-major bleeding was noted in about 11% of patients receiving apixaban as compared with about 15% for those receiving vitamin K antagonists. A major or clinically relevant non-major bleeding was observed in about 16% of patients receiving aspirin as compared to 9% receiving placebo. And that's why the patients in the apixaban group had a lower incidence of death hospitalization than those with vitamin K antagonists and similar evidence incidence of ischemic events. And these data, of course, support the use of apixaban and B2Y12 inhibitor. Here is again another evidence for single antiplatelet, which is preferably B2Y12 inhibitor plus the anticoagulation, which is here NOAC apixaban during the first 6 months of most bleeding for the aim of decreasing the incidence of bleeding, especially for those patients with high risk of bleeding in such a situation like AF, acute coronary syndrome, especially with PCI and UL antiplatelets. Here is another important data, which is reveal again the major bleeding across WACS real-world meta-analysis from different studies, from different trials, that apixaban versus dabigatran give also a favor for apixaban as regard bleeding, and apixaban versus rivaroxaban gives again the favor for apixaban, especially in those patients with upper GIT, high risk of bleeding. Here is the whole story. The algorithm for the antithrombotic therapy in non-ischemic elevation acute coronary syndrome patient with atrial fibrillation undergoing percutaneous coronary intervention. The default strategy, as we all know, 1 week triple therapy. Then from 1 week till 1 year, we have to use dual therapy with NOAC or plus single antiplatelet therapy. Then after 12 months, we use the NOAC alone. For those with high bleeding risk, like such like our patient, 1 week for that. Then from 1 week to 6 months, NOAC plus single antiplatelet therapy, and after 6 months thereafter for only the oral anticoagulation NOAC. For those with high ischemic risk, we can extend to 1 month. For that, then we use the double therapy for 1 year, and then single therapy with NOAC after 1 year. So let us back to our patient again to finalize the treatment strategy for this patient. Upper GI endoscopy revealed flat pigmented spot, which, as I mentioned, according to the FARSI classification for upper GI endoscopy is considered low risk stigmata class 2C. For that data derived from the upper GI endoscopy, the integrated decision was to continue DAPT for 1 week, switch TICA to clopidogrel, and resume NOAC with the lowest effective dose of apixaban 2.5 milligram BID after 4 days because there is no recurrence of bleeding, and to continue on clopidogrel and apixaban for 6 months, then on apixaban only thereafter. And of course, the long-term BBI is of utmost importance, and to avoid, of course, the non-steroidal anti-inflammatory, which was really blamed for the patient situation. And finally, my take-home message here is the upper GIT bleeding with acute coronary syndrome carry a very high risk of ischemic event and death. Of course, integrated management with gastroenterologist is mandatory for control of bleeding and the tailoring antithrombotic strategy according to the risk stigmata, as we found, as we had from the upper GI endoscopy. And of course, implementation of the recent evidence as regard the duration of antithrombotic and type of antiplatelet and oral anticoagulation with less bleeding risk is also very important. And finally, we have to keep in mind the balance between the risk of recurrence of ischemic events and the bleeding risk. And thank you for your attention.
Thank you, Professor Said, for this wonderful case. I think I can summarize your case into 3 points for me. Usually, to make it simple for the audience. Number 1, if you have atrial fibrillation with the ACS, you should have only 2 drugs, only 1 antiplatelet and 1 on triple therapy for 1 week for all of them, whether stable or acute coronary syndrome, and then 2, and then we give 2 only, 1 is the P-12. The second is antithrombotics. The P-12, which is less risk of bleeding, high risk of bleeding, you have to use clopidogrel. I know that you can use ticagrelor, but if you have a risk of bleeding, the best is clopidogrel. The second, whether any NWAC, but if you have a GIT bleeding, apixaban is the best. Am I right for this?
Yes, of course.
This is to summarize the case. Fred.
Congratulations, Professor Fraga. Really wonderful presentation.
Thank you very much.
I would like maybe for you and sort of how this goes in Egypt. As you know, the Augustus investigators show that, in fact, it really requires interaction between sort of the arrhythmia people thinking about sort of the risk of stroke in patients with atrial fibrillation, but also in those patients with acute coronary syndrome, risk of sort of rethrombosis or, another ischemic event. And, as you know, they did a subgroup, sort of a post-hoc analysis looking sort of at that sort of day 1 through 30, and then 30 days sort of on. And I'd like to get your thoughts about sort of, how does it work in Egypt? We spend a lot of time talking back and forth about sort of the pros and cons, of continuing triple therapy, maybe a little bit longer if my interventional colleagues are worried about, their result and having rethrombosis, et cetera. Because as you know, there at least is a little bit of data to suggest that if, that there is a little bit of work on the edges that can provide some variability and flexibility to our clinicians.
Yes, I totally agree with you, Professor Kosomoto, because sometimes the scenario is much more challenging than the scenario I presented in my case. Sometimes we have, for example, a left main. Sometimes we have an ostial LD or multivessel disease or bifurcation, which we have to deal with a complex procedure, which carry a high risk of ischemic event. It is a much challenge. And I think, again and again, we have to remember the first slide I presented, because if we have not kept the bleeding in front of our eyes very carefully, also, just like the ischemic risk, the patient may subjected to bleeding, which again carry a high risk for ischemic events. So for those patients with high complex lesions or high complex procedure with high thrombotic risk, we can consider, yes, a little bit aggravation of our antithrombotic strategy. And I can hear back again to Professor Sobhi when asked that we can use the ticagrelor in spite of clopidogrel. Yes, we can use it if we have the trust from the gastroenterologist that we have low risk stigmata from the upper GI endoscopy, for example, or from the neurologist. If we have a low risk of rebleeding intracranially, if we have such a data from the integrated management, we can sometimes up-titrate our management, such like using the ticagrelor in spite of clopidogrel. Sometimes we can use 5 milligram apixaban instead of 2.5 milligram because we still have low risk of bleeding.
Yeah.
It is a challenging, and we have to be integrated management with co-management with the other specialty involved.
Dr. Lamia? Dr. Lamia, you have any comment? Okay.
Thank you, Dr. Farag, for your nice presentation. I'm actually have enjoyed it so much, especially because I'm not an coronary intervention, and usually I don't face these problems, actually. But actually, I think that if the scenario is become more aggressive and you have a recurrent bleeding later on, what will you do? Even if you are on dual therapy, a single antiplatelet and NWAC, do you think to stop any of these drugs earlier, and in what situations do you choose to continue on anticoagulation or to continue on antiplatelet therapy for intervention, stenting or BCI?
Again, Dr. Lamia, and I'd like here to mention that we have to balance, as my last take-home message, we have to balance between ischemic and bleeding risk. If we have the balance for going on for the ischemic risk more, we have to use the maximum antithrombotic treatment we can give with, here is come the rule of the close monitoring of the patient. The close monitoring and rechecking and re-examination by the cardiologist or gastroenterologist is very important, because this make us keeping up and prolong the antithrombotic treatment we intensified because of the high thrombotic risk for these patients.
I can answer this question. Okay, Said, can I help on this question? I know that you are meaning that you have a recurrent bleeding. You have to sort the cause of bleeding, but sometimes if you know that this patient high risk of bleeding, you have the stent, you have the duration, you have the atrial fibrillation. So we have a change. We have trials of Biofreedom stent, the leader trial. We have Onyx, which is the clear one. We have also the Science 2890, which is very important. These are important trials for the 3 stents. You can use it if you have a risk of bleeding. Then the second, you can the duration. There is a lot of trials saying that SAP is better than DAPT. Maybe aspirin. I believe in this kind of patient, aspirin has no role, because already starting with the worst, then we will have already 4 trials. So we have to shorten the duration. The problem is that if you have acute coronary syndrome or a stable patient, if you have a stable patient, you continue 1 month or 3 months. If you have acute coronary syndrome, according to the guidelines, maybe 6 months, 3 months. If you have a risk of bleeding 3 to 6 months, it's depending, individualized. And all of this, you have to start. Regarding the GIT bleeding, which I'm concerned, as Dr. Said said, he changed it from rivaroxaban to apixaban, because this will cause more GIT bleeding. But if you have another non-GIT bleeding, you have to search for the cause of bleeding.
I'd like to add,
Said?
Yes, I'd like to add what Professor Sobhi said. It's a very important question, Dr. Lamia. And I mentioned it already in my presentation, that we used the current generation of the stent. It's very important, because most of the generations now, sometimes we can now shorten the duration of the dual antiplatelet therapy in most of the current generation stents, and especially, as Professor Sobhi mentioned, the Biofreedom or even the Onyx. But I have, Professor Sobhi, if you allow me to mention Lamia a question, because electrophysiologist with us. Do you think in such a situation, if we have, and Professor Kosomoto also, if we have the facility to do atrial fibrillation ablation, this will affect the future for the patient as regard the antithrombotic treatment, the risk of thromboembolization, and we can intensify our antithrombotic treatment? Dr. Lamia.
I think, Dr. Fred, if you'd like to answer this question, you are our expert here.
Well, I don't know about that, but again, I think that I certainly wouldn't do it in this setting just because the patient's ill and an ablation is an elective procedure at the end. I did want to add one other important thing, though, is that holistic approach to the patient. Because, we have, from all of the trials using the DOACs, have looked at sort of what the stroke risks are when we stop anticoagulation for a period of time, for some sort of surgical procedure, et cetera. And there's no question that can be done. In many cases, the risk of stroke is a little bit higher if you were to kind of use sort of the back of the envelope type of amount, but the absolute risk is relatively low. And so this is one where, again, you have someone, let's say, who's continuing to bleed, let's just say for argument's sake, but also then he or she's on anticoagulation for paroxysmal atrial fibrillation who's now in sinus rhythm. Well, I actually think that it is reasonable then to actually go on a drug holiday for the anticoagulation, because the overall risk of stroke there is lower, right? So it's always thinking about the patient in the middle and then having us all talk about those competing risks and then making a decision for that particular patient, what their risk is for bleeding, of course, from our GI colleagues, what their risk for stroke is, that's what we can provide input. And then obviously from our interventional colleagues, sort of what is the requirement for taking care of the ACS? And it's that balance that comes together. And I want to ensure that our audience knows that I think it's perfectly legal to stop the anticoagulation in someone who is at relatively low CHADS-VASc score, who might be in sinus rhythm, for example, or in persistent AFib even. Again, because I do think that it is weighing sort of the risks of all of these decisions that we make, ultimately to make our best guess at how best to take care of the patient. So I just wanted to ensure that people know that you can stop the anticoagulation too, that that's okay.
But I want to clarify something. AF ablation, it is a rhythm control rather than prevention way from the thromboembolism events. Even according up to the guidelines, it will still, if the patient had a CHADS-VASc score more than 2 or equals, even after AF ablation and verifying that there is a successful AF ablation, we still continue on antithrombotic medications. I think in this patient, it will benefit more from something like Watchman device to avoid the oral anticoagulation because it is proven. Yes, but the AF ablation has no role in decrease in discontinuation.
Left atrial closure device.
Watchman device like left atrial closure device, but AF has no role in prevention of risk of stroke.
Yes, I want to be clear.
Any source of bleeding, ablation, yes, left atrial closure. Thank you very much to the site for this wonderful case. I think we are late, but we have a wonderful case with you. Thank you very much.
Thank you.
To be with us to have the last case of Professor Ahmed Mukhtar, Professor Cardiology, Alexandria University, is a pioneer in the EPS in Alexandria and in Egypt with Dr. Lamia Alem. All the EPS, we are lucky to have these wonderful guys and girls and young lady. Dr. Ahmed is going to speak about paroxysmal atrial fibrillation and what you are going to do.
Thanks, Dr. Sobhi. It's my pleasure to be with you today and with this very nice faculty, Dr. Fred, Dr. Lamia, Dr. Said. My case presentation will be upon paroxysmal atrial fibrillation. For sure, we have a very common atrial fibrillation, a very common health problem, which is highly prevalent, affecting more than 40 millions all over the world. We have 1 in 3 lifetime risk for development of atrial fibrillation. It's more common with advancing of age and increasing burden of multiple risk factors. It affects the quality of life, affects the hospitalization, lead to significant increase in mortality, stroke, LV dysfunction, and decline on cognitive function. So we are dealing with a prevalent disease affecting the health and the economy systems and affecting the quality of life. Our case is a 64-year-old male known to be hypertensive, controlled on ACE inhibitors, presented to the outpatient clinic. He had been complaining of long history of brief episodes of palpitation and flutters, but it was very infrequent, maybe once per several months, and lasting for a few seconds or 1 minute maximum. Currently, it increased in frequency to be occur on semi-daily basis, lasting for up to 20 minutes with marked limitation of the physical activity and severe dyspnea and shortness of breath. He was evaluated by the primary care physician, and ECG revealed the presence of atrial fibrillation with rapid ventricular response. So the initial evaluation should be the 4S atrial fibrillation scheme: S for stroke prevention, symptom severity assessment, severity of the AF burden, and evaluation of the substrate severity using various scores: CHADS-VASc score, AIHA symptom score, and the quality of life questionnaires, type of atrial fibrillation and total burden in atrial fibrillation, and assessment of the left atrial function using dedicated imaging and evaluation of the fibrosis in the left atrium. So the diagnostic workup should go through the medical history taking, 12-lead ECG, laboratory function, including thyroid, kidney, electrolytes, and CBC, transthoracic echo. Sometimes we do ECG monitoring to check the adequacy of rate control and to correlate symptoms with AF recurrence, transventricular echo, especially when we need cardioversion or assessing the valvular severity, and other dedicated imaging according to the presentation. So his lab workup was normal, including renal, thyroid, electrolytes, and so on. His echo showed only mild left ventricular hypertrophy and mild dilation of the left atrium. The diameter was only 43 millimeters with good systolic function and no significant valvular lesion. Treatment also applies the APC scheme or APC pathway, A for anticoagulation and the stroke prevention using the SHAD-VASc score and identification of those who will need anticoagulation or other non-pharmacological measures of anticoagulation like Watchman device as such mentioned. P for better symptom control, including rate or rhythm control strategy, either pharmacological or non-pharmacological measures for rate and rhythm control. And C for control of cardiovascular comorbidities and other risk factor management. So our patient was only SHAD-VASc score was only 1 because he is hypertensive, his age below 65, and he doesn't have any other comorbidities. So oral anticoagulant for this patient is class 2A. He should be considered to receive oral anticoagulant. In the background of therapies of all patients with atrial fibrillation, unless there is hemodynamic instability, we should start with rate control till we prepare for the further plans, either rhythm control or continuation of the rate control, aiming for lenient rate control below 110 and assessing the symptoms before we go for more strict rate control to keep the heart rate below 80 beats per minute. So the initial plan was to give the patient beta blockers for rate control, and he was kept on metoprolol and apixaban 5 milligram twice daily for anticoagulation, and we prepared the patient for cardioversion. Why we choose rhythm control strategy for this patient? Rhythm control strategy used only to reduce AF-related symptoms and improve quality of life. Did not correlate with the mortality and did not affect the anticoagulation. So all patients should receive stroke prevention, rate control, cardiovascular risk factor reduction, and then evaluate the symptoms. If the patient have significant symptoms correlated to the atrial fibrillation, so this patient should be offered rhythm control strategy, especially when he have some favorable factors, such as young age, first episode or short history of atrial fibrillation, tachycardia-induced cardiomyopathy, normal or near normal left atrial functions, with minimal left atrial remodeling, no significant structural abnormalities in the heart, those with difficult rate control, patient with temporary events, or patient choice. Our patient had no significant structural heart disease, and we have a small left atrium, not markedly dilated, so the remodeling changes is still in the earlier stage. So we decided for rhythm control strategy, which could be achieved either by antiarrhythmic drugs, pulmonary vein isolation in paroxysmal patients, or a more dedicated advanced surgical or thoracoscopic ablation. Before we proceed for cardioversion, we should check the hemodynamics. If the patient is unstable, cardioversion is emergency. But if we have a stable patient, we should look for the anticoagulation. Is the patient is previously anticoagulated or not? Our patient was not previously anticoagulated. So we depend upon the duration of the AF episode. If it is less than 48 hours or more than 48 hours, those with more than 48 hours need either 3 weeks anticoagulation prior to cardioversion, or they need transesophageal imaging to exclude the presence of thrombus. Our patient have a short duration, so with a low SHAD-VASc score, so we decided to cardiovert the patient after we start the anticoagulation. We have either electrical or pharmacologic cardioversion. We started flecainide for cardioversion, and we successfully restored sinus rhythm. So then we have a consultation with the patient for the treatment plan, either to continue on antiarrhythmic drugs or to proceed for ablation. Based on the guidelines, those with symptomatic atrial fibrillation, paroxysmal, should be considered for antiarrhythmic drugs as an initial plan, and early catheter ablation is only class 2A. So in this patient, we decided to use antiarrhythmic drugs, but we should know the basis of therapy using antiarrhythmic drugs only to reduce the AF-related symptoms. Its benefit is only modest. They reduce rather than eliminate AF recurrence. When one fails, we can shift to another drugs poor arrhythmias and safety is an important issue, and that choice independent on the safety rather than the efficacy. So we have to start with the safe, even if it is less effective. In those with minimal or no structural heart disease, like our patient, we have to start with dronedarone, flecainide, bupropion, or sotalol. So the patient was kept on flecainide 50 milligram twice daily. The patient was doing well for 1 year. He still have a few recurrences, but they initially were sporadic, transient, not affecting the quality of life. Then they became more long-lasting and more symptomatic, negatively impacted his quality of life. So we have a consultation with the patient either to increase the flecainide dose, change to alternative antiarrhythmic drugs, consider catheter ablation. And currently the patient opted for ablation strategy. And this class 1 indication of the guidelines after failure of at least one of class 1 or class 3 antiarrhythmic drugs. The most commonly used energy source is the radiofrequency ablation, and this in atrial fibrillation depends on a point-by-point application of the radiofrequency current to create wide antral lesions around the ipsilateral pulmonary veins. So the patient underwent this WACA, wide antral circumferential ablation strategy, and he felt well after the procedure. He was kept on anti-arrhythmic drugs for 3 months planking period, and then it was discontinued. The patient still have some sort of tiredness and not doing well without definite atrial fibrillation recurrence. Using the routine Holter monitoring failed to demonstrate a definite AF recurrence apart from frequent premature atrial contractions. So implantable loop recording was implanted, which revealed the presence of a highly significant burden of atrial fibrillation. Flecainide 100 milligram twice daily was reintroduced, but did not affect either symptoms or the burden of atrial fibrillation detected using the implantable loop recording. So treatment option, increase the dose, shift to another drugs, redo ablation, or more thoracoscopic or surgical ablation. We thought about redo ablation, but using a different energy source. At this time, it was the cryo ablation, aiming for single shot application for each pulmonary vein, creating a wide antral ablation line. And this was demonstration of cryo case showing the coronary sinus catheter followed by the transseptal axis, and after this we do selective pulmonary venography to identify our targets of pulmonary veins. And after this, we proceed with the FlexCath chief catheter cryoballoon. Then we do pulmonary vein occlusion, and we test this occlusion using contrast material into the pulmonary veins and make sure that it is not leaking into the left atrium before starting freezing of these pulmonary veins. And we do this for each one of the pulmonary veins, starting with the left superior, then left inferior, then right superior, then right inferior. Importantly, we should take care during application of the cryo source in the right veins on the right side to avoid injury for the phrenic nerve using a catheter stimulating the phrenic nerve in the right superior in the superior vena cava to make sure that we have adequate diaphragmatic contraction during the application of the cryo in the right veins. And this is how it will look if you have a good sealing of the pulmonary veins. You have an injection and the contrast stay in the pulmonary vein and not leaking into the left atrium to make sure that you have a complete occlusion of the pulmonary veins. And during application, you will have this, after freezing, you will have this contrast staying beyond the balloon. What was important that during the mapping portion of the ablation, we have reconnection, which is the main source of AF recurrence after a first procedure of paroxysmal AF ablation, reconnection in 3 out of 4 pulmonary veins. Only the right inferior pulmonary vein remains silent while the right superior pulmonary vein was the main source of premature atrial contraction and the initiator of the atrial fibrillation. After the ablation and discontinuation of the flecainide after the planking period, during follow-up, the patient was asymptomatic, no documented recurrence either in ECG or implantable loop recording. So what's different between radiofrequency and the cryo? Actually, radiofrequency need a higher learning curve. A lot of experience is needed in the radiofrequency because it is technically demanding, requires point-by-point application, and be sure that you are not creating gaps to decrease the recurrence and the atypical forms of flutters that occurs after ablation. Actually, it needs more navigation system and mapping system, challenging in catheter stability, also inconsistent data between centers and operators due to the higher learning curve. While the cryo has the advantage of being not operator dependent, have a shorter learning curve, more consistent data between centers, and fewer affection of the extracellular matrix and endothelial disruption with minimal stroke and thrombus formation. An interesting field in the ablation is the pulsed field ablation. Here we use an electric current to create what's called electroporation. This electric current causes disruption and formation of pores in the cell membrane, leading to cell death. The myocardial cells actually is very sensitive to this form of current. So application of this form, either unipolar or bipolar pulsed field electricity, create selective myocardial damage, not affecting the surrounding tissue, so minimizing collateral damage. So the main benefit of this pulsed field application is that you will have a pulmonary vein isolation in a very short duration. In 3 minutes, you could achieve pulmonary vein isolation, and it's actually durable without collateral damage. The durability was checked using electroanatomical mapping immediately post pulsed field application and 3 months later, and it confirmed that they have 100% pulmonary veins remain isolated after these 3 months. Also, the tissue specificity and the absence of damage to the surrounding structure was confirmed using CMR, which represented the presence of fibrosis only in these pulmonary veins, with no affection on the phrenic nerves, esophagus, and so on. So it has the benefits that you do not need to do esophageal protection during the procedure. So the main difference between these 3 different forms of energy sources, that using a cryopalone or radiofrequency, you could achieve collateral damage to the esophagus and the phrenic nerve, while in this pulsed field, you have selective tissue injury, minimizing the collateral damage, and another that you have 100% durability in the isolated veins compared to only around 80% in the palones and radiofrequency after 1 year. Currently, the ADVENT trial, which is examining one of the pulsed field catheters, the FARA Pulse, is is still ongoing and started recruitment this March, aiming for in US in 35 centers in US, enrolling up to aiming up to 900 patients, comparing the RF and the cryo to the pulsed field source of energy, and we are waiting for these trials because we expect this would change the practice in AF ablation. My summary is AF is a common health problem associated with increased cardiovascular morbidity and mortality. Rhythm control strategy recommended to improve symptoms and quality of life. Ablation is superior to antiarrhythmic drugs and maintenance of sinus rhythm. Improvement in ablation technology increases success while minimizing the risks of complication. And thank you.
Thank you, Ahmed Mukhtar, for this. Usually when you give the mic to the EPS man, he speaks with a different language. Usually this is my idea. I think Fred and Lamia and Ahmed
Yes,
is taking
it's a very specialized presentation.
a very specialized. Yeah. I know,
Yes.
but we have to.
Thank you.
We have to.
I
Go
will
ahead,
short
Lamia.
the time, yes, because we are out of our time now. Thank you, Ahmed, for your excellent presentation. You presented the typical case for AF patient, paroxysmal AF patient, when we need to do an AF ablation. The class is still up till now in the ECC guidelines in paroxysmal AF. Class 1 indication is to do an AF ablation in patient who is resistant to at least one antiarrhythmic medication. But what I have one question for you, Ahmed. We are used to choose cryoablation as a first way for AF ablation or a first procedure because our first technique is to do a PVI. And when there was a recurrence, or recurrent EF, we would choose an RF ablation because of to check the reconnections of pulmonary veins, and if we find the pulmonary veins are isolated, we search for non-PVI triggers.
Yes.
Why you do the reverse?
Yes. Actually, the common practice, it's according to the center and the experience, local availability of the energy sources and the local experience of the team. Actually, usually, as you just mentioned, we should start either with cryo or radio frequency. But if we have recurrence, so what we are going to do, either to re-isolate reconnected veins, or if they are all isolated, you should search for a non-PVI triggers. So in this scenario, you should be prepared to do radiofrequency ablation. The strategy was different in this case because this case underwent radiofrequency ablation outside of Egypt. It was presented to us with AF recurrence. What I am happy to use and more confident to use is the cryo. So what I did is I just checked for if we have reconnection or not. I was prepared with the cryo and the radio frequency, but when I faced with a completely reconnected veins, I was happy that I'll do a first procedure and I'll do a cryo as a first procedure, despite it was a redo procedure. But if I was prepared that if I have a completely isolated veins to go for radio frequency.
Excellent. Actually, when you find the patient with he has a paroxysmal AF, it is usually when there is a recurrence, most probably it will be a pulmonary vein reconnections, yes. Especially in late recurrences less than 2 years. Yes. But if he has a late AF recurrence more than 2 years, it may be there is a non-PVI trigger. So you do the unusual way, but it is the excellent way. Thank you. I have no comments. No other comments.
Fred, do you have any comment, Fred?
First of all, congratulations, Dr. Mokhtar. Beautiful presentation, really excellent. I don't disagree with anything that has been said here, and I share a lot of the thoughts of the other electrophysiologists, the other people that speak the foreign language here. A couple things, though, that I will say. There have been several randomized trials looking at RF versus cryoballoon, and they basically have been essentially equal, just so that the audience knows that. I personally, for a first ablation, similar to Drs. Mokhtar and Alam, will use a cryoballoon. And why is that? Well, a couple of reasons. One is that I'm old. I've been doing AF ablation since the mid-90s. And, when we look at our recurrences, it was interesting. Oftentimes, even if it was from sort of reconnection, it would often be on the edges, on that antral sort of region. And we were more in PV isolation back in the late 90s and early 2000s, as opposed to making the larger lesions that we do now with RF. What I'm really struck by with cryoballoon is that not only does it make an encircling lesion, but it's actually a fairly wide lesion. And for that reason, I think it gets a lot of that, what I call cuff tissue, which frequently, I think in some patients is in fact a trigger to the atrial fibrillation. In addition, the other advantage that cryoballoon ablation has, and we've looked at this, even with our attempts at using no X-ray, et cetera, with RF, et cetera, what's interesting, when we looked at the X-ray exposure in cryoballoon ablation, it is so small. We've actually put a radiation monitor outside the lead. So, sort of outside the lead. And it's interestingly, when we then evaluate the actual exposure with the new sort of radiation techniques, et cetera, it's essentially less than a trans-Pacific flight from here to Tokyo. So it's incredibly sort of low radiation. And in addition, the procedure happens quite a bit faster. And because it's faster, I just think there's less likelihood for complication. But as Dr. Alam points out, oftentimes after this has been done, then radio frequency energy is required. I will say one additional thing with the balloon, you can use the balloon kind of going across gradually this posterior wall, which is often a spot where these premature atrial contractions come. So in fact, the balloon can be used in addition in experienced hands beyond just isolating the pulmonary vein. But I like it because it makes a big circle all at once, and it really is the right tool for the right procedure. And for someone who has never had an ablation before, where you're going to have to isolate a lot, or in your case, Dr. Mokhtar, where a lot of the vein was reconnected, then certainly, absolutely a really excellent approach. So congratulations, first of all, on this wonderful presentation, and second, on a great success with that patient.
Thanks.
Fred, I have a question from the audience regarding the.
And I have a question. I'm back.
I'm just speaking. You can speak to me regarding apixaban and generic type. In Egypt we have a lot of generic drugs regarding rivaroxaban, apixaban. We don't have dabigatran like before, but we have these two drugs. We just have edoxaban in Egypt. The problem that we don't have a true generic. We have maybe only copies. We don't have a comparison. How can we manage this in the market? Taking into consideration that the health insurance now is reimbursing the patients with the original one, the patient can pay some form of peanuts money to instead to have to take care of all the drug. So how do you manage this in United States?
Yeah, so a great question, right? I mean, that's a huge issue is cost of care. And, when I have some of my patients who stay on anticoagulation with warfarin because, they have stable INRs and it's very, very inexpensive compared to some of the other medications. Oftentimes, though, we can find a drug that is on a patient's drug plan that, is in fact covered. So, generally, even though they are different medications, you can find one that sort of is palatable for the patient because it is a cost issue, and that's important. The second thing that I will say is I'm a firm believer in generics. I believe that they are excellent medications in many cases, but the problem is, at least in the United States, and I don't know what it is in Egypt, sometimes even though it's, quote, a generic, it won't exactly be the same medication. And so oftentimes, even though the active agent might be correct, the pharmacokinetics and the way that it sort of works in the body, the pharmacodynamics, as we call it, can be different, and that is an issue that brings up concern. So again, every country is different, and in the United States, every patient is different because everyone has so many different health plans. So unfortunately, and this is a problem, there's a lot of wasted resources. I know you guys spend a lot of time looking for the right medication, et cetera, for the patients, as opposed to just simply saying this is the right medication and hopefully having a health system that will allow that to happen. We spend a lot of time, trying to get the right medicine and a lot of resources with that, and it increases the inefficiency of the physicians and even the entire healthcare system because of that.
Annie, yes. Annie, you have a question, I think.
Yeah. Is there time for a last question?
Yes. Okay.
Okay.
It's a simple question.
The difficult atrial fibrillation, very simple. The difficult atrial fibrillation whom we cannot control the heart rate, and the AF is actually pushing them into some kind of heart failure. Some brave person attempted ablation, didn't work a couple of times. And I'm proposing, attempts, because the patient has a left atrium of 5.5 or 6 or something, lose interest. They're not really interested in ablating the AV node and pacing those patients with dual chamber pacemakers. It's something, it's like amputations as far as they're concerned. It's something like they don't like to do very much. So your thoughts?
I think this is the only way of management for these patients. If you have a drug refractory atrial fibrillation and failed the previous attempts of atrial fibrillation, the only way of management is AV nodal ablation and biventricular pacing.
Okay.
Yes, this is the only way if you failed multiple times. But I think the problem is controllable on controlling medication. So the only way is to do an AV nodal ablation and put an biventricular pacing in these patients.
Okay. Dr. Lamia, you say this is the only way. Every single year, I've been getting a team from Eindhoven, from Holland, to the National Heart Institute. There are 2 cardiac surgeons and a couple of nurses, and they do minimally invasive maze. They actually open the patients. They're surgeons. They're cardiac surgeons, and they do a minimally invasive maze. And I've actually seen quite a few successes in those patients. So I don't think it's the only way.
No,
why are we not talking to the surgeons?
This is the only, Dr. Hani, because what you mentioned is under the umbrella of a previous ablation failure.
Right.
Yes.
But it's not the only way. I mean, electrophysiologists realize there are surgeons.
And actually, another problem is that our surgeons has no interest in the EB surgical procedures. Actually, here in Egypt, they like more the coronary vascularization and mitral valve prosthesis. Actually,
the surgeon who comes from
this is the problem.
Okay.
Up till now, we have no surgical procedures for EB.
Okay. Thank you.
Can you have your last quotation regarding this issue?
Yeah, it's a question that, surgical, we have a very busy surgical service here that it will do ablation in some cases, oftentimes, though, in those patients who are having concomitant surgery. A couple of things, though, particularly with this, what's called a convergent procedure. But I'll tell you that the converse, Hani, is that I get a lot of patients in my practice who've had minimally invasive surgery who continue to have atrial arrhythmias, and then I have to sort of think about sort of what is sort of the mechanism and the cause, et cetera. So it's like all things have, their place and value, but, identifying the value is identifying the mechanism for that particular patient's atrial fibrillation. Now, in some cases, it is sad that your electrophysiologists lose interest in the AV nodal ablation and CRT or his bundle pacing, as Drs. Mokhtar and Alam have brought up, because that is certainly a viable option in certain patients. The problem is that it's irreversible. And once you've kind of done it, you can't go backwards. And that's kind of the problem associated with it. So I think that's why sometimes you'll run into hesitancy amongst the electrophysiologists because of that. Not necessarily because they've lost interest, but because of that concern that it sort of, you can't do anything else. And even though CRT is helpful and his bundle pacing is helpful, is not as good as sort of what we got originally from, sort of from Mother Nature, as it were. And so clearly something that's there, but has to be used judiciously.
Thank you.
I think we come to the end. We have a masterpiece today of a live program in 2.5 hours. We extended 30 minutes more because we have a lot to discuss. I think if this is recorded, you can see that we have all the trials updating atrial fibrillation by Fred Kusumoto, which is it's an honor to have with us, Dr. Fred from Mayo Clinic, and also about the new technology of diagnosis, atrial fibrillation, the wearables, and subclinical, what's known as subclinical atrial fibrillation, which I like your slide about subclinical AF, and we have to look to the EHRA together with the Schatz-Vask. And finally, we have two important cases which are discussed about the dual therapy, triple therapy, how to make it treat the bleeding by Professor Said Farag. Actually, he did a great job in a great case. And finally, our EPS man, Ahmed Mukhtar, he started clinically and ended by a very difficult, sophisticated techniques. I know this with the EPS. Thank you, Ahmed. So I choose Lamia because she has to discuss with you and Dr. Fred as well. The EPS, I'm not an EPS man, but I suppose when I was young to be an EPS man, but luckily enough, I go to be interventions. But nowadays, if you come back, maybe I change my mind to go to the EPS because at that time, there's no that such advanced technique with the EPS. I think we are a great team, clinician, intervention cardiologist, and the EPS. And I'd like to thank all of you, Professor Hani Raghi, Professor Lamia, Professor Said Farag, Professor Ahmed Mukhtar, and finally, Professor Fred Kusumut, which enriched this Alive program. I'd like to thank Pfizer for sponsoring this, for the ECC chapter, and also for Icon Company for technical support. And thank you very, very much. I think we can stop and have a picture with Icon regarding this. It will be a wonderful picture for all of us. Thank you very much, and have a nice weekend, Fred. Thank you. Goodbye.
I'm honored. Thank you.
Good night.